Welcome to the deep dive. Today we're tackling clindamycin. It's a really fascinating antibiotic, one that's actually been a staple for quite some time, but still plays a pretty vital role in medicine today.
It really does. You can think of it like um, a disruptor for bacteria. It essentially stops them from building the proteins they absolutely need to survive and multiply.
And it came about by modifying another antibiotic, right? Lincomycin.
Exactly. A chemical tweak, specifically adding a chlorine atom, turned lincomycin into clindamycin. And it's relatively small, molecule-wise, but packs a punch against a lot of different bacteria.
It does, and you see it in different forms too, don't you? Like not just pills.
Oh, yeah, absolutely.
Yeah.
You've got the IV solutions, often mixed with saline for more serious systemic infections. Then there are the oral capsules, probably the most common form people think of.
And topicals too, right?
Mhm.
Creams and gels.
Yep, topical solutions, gels, creams,
Mm.
used directly on the skin, often for things like acne. So it's pretty versatile in how it gets delivered.
It really is. And that versatility and its long history are exactly what we want to dig into today. We've gathered quite a bit of info, how it got approved, how it actually works in the body, how it's manufactured, even some of the, let's say, regulatory hurdles and discussions around it.
hmm The goal is really to give you, our listener, a solid, rounded picture of clindamycin, its history, its uses, the science behind it, and maybe some surprising facts along the way.
Exactly. So let's get started. Where should we begin? Maybe the history, the approvals?
Sounds good. Looking at the regulatory journey is always interesting. Clindamycin isn't new, as we said. The initial FDA approvals, the NDAs, or new drug applications, they go back quite a way.
To the 70s, wasn't it?
That's right, 1972 initially, and then another significant approval in 1989. But then more recently, in 2016, there was another submission, NDA 2800A3.
Okay, so what was different about that one?
Well, it was filed as what's called an original 505(b)(2) application, which sounds technical, but think of it as a pathway where the applicant can rely partly on existing studies or findings the FDA already has on file, maybe for the original lincomycin or earlier clindamycin approvals, rather than doing all the studies from scratch.
Ah, okay, so building on previous knowledge, in a way, makes sense for a drug that's been around.
Exactly.
Yeah.
But it still requires demonstrating safety and effectiveness for the specific product being proposed. And that 2016 application, well, it wasn't quite the end of the story even then.
Oh, what happened next?
Later that same year, October 2016, there was an amendment submitted. This specifically addressed something called PLLR labeling,
PLLR, what's that stand for?
Physician Labeling Rule. It's all about standardizing the format and content of the prescribing information that doctors receive, making sure it's clear, organized, and highlights the key information effectively.
So constantly refining how the information is presented to make it safer and easier to use.
Precisely.
Yeah.
And the FDA really does focus on the details there. For that 2016 application, for example, there were discussions about the actual container and carton labeling.
Like the box it comes in.
Yeah, the box, the bottle label. The FDA and the applicant, a company called Celerity, agreed on specific changes to improve readability and, importantly, reduce the risk of medication errors.
What kind of changes?
Things that might seem small but are based on human factors research, like using clear black text on a plain white background and putting a distinct black outline just around the part that states the drug's strength.
Little visual cues to make sure the right dose is grabbed off the shelf. Makes sense.
It does. Preventable medication errors are a huge focus. And it wasn't just the outside packaging. The detailed leaflet inside, the full prescribing information, also got scrutiny.
Right, you mentioned the PLLR rules. What else was important there?
Well, the FDA emphasized strict adherence to the regulations, specifically 21 CFR 201.56. This dictates the structure. For instance, the main heading must be full prescribing information, bolded, all caps right at the top.
Okay. Standard format.
And crucially, if the drug carries significant risks, the very first section must be a boxed warning, also bolded. This is for the most serious potential side effects, so it needs to be impossible to miss.
Front and center. So formatting isn't just about looks, it's about safety communication.
Absolutely critical. Now, stepping back from the labeling to the drug substance itself, clindamycin phosphate. How do we ensure the quality of that starting material?
Good question. Is there a standard for that?
Yes, there often is. In Europe, for instance, they use something called a CEP, a Certificate of Suitability to the European Pharmacopoeia monographs.
Okay. A CEP.
Right. And we know from regulatory documents that the clindamycin phosphate used in some products has a CEP, and based on that, it has a retest period of 3 years when stored under the specified conditions.
So that certificate is basically a quality guarantee for the active ingredient itself, showing it meets recognized standards.
Essentially, yes. It streamlines the regulatory process by confirming the quality of the raw material up front.
Got it. Okay, so we've covered the approvals, the labeling focus, the quality control. Now, let's shift to what clindamycin actually does clinically. What's it used for?
It's used for quite a broad spectrum of bacterial infections. One really common and important use is surgical prophylaxis.
Preventing infections before they start during surgery?
Exactly. Especially in patients who have allergies to beta-lactam antibiotics, like penicillin or cefazolin, which are often the first choice for prophylaxis. Clindamycin is a key alternative there.
Ah, okay. So if you're allergic to penicillin and need surgery, you might get clindamycin beforehand. What else?
It's also used in pregnancy, both for preventing and treating certain infections. And it's important in managing diabetic foot infections.
Those can be really nasty and hard to treat, right?
They can. And clindamycin is also frequently used for bone and joint infections. That includes infections related to fractures or even infections around artificial joints, like hip or knee replacements.
Does it get into bone well? That seems important for those kinds of infections.
It does. And that's a key reason for its use there. We can talk more about its distribution later, but yes, its ability to penetrate bone tissue is a significant advantage.
Okay, good to know. What about specific bacteria? Is it ever a first-line choice?
Sometimes, yes. For instance, in pregnant women allergic to penicillin who have group B strep, Streptococcus agalactiae, clindamycin can be a primary option to prevent transmission to the baby during birth.
But there's a catch there, isn't there, with resistance?
There is, unfortunately. Resistance is a growing concern. In some areas, like parts of China reportedly, resistance rates in group B strep are high enough that clindamycin might not be reliable anymore for this purpose. So local resistance patterns are crucial.
A reminder that antibiotic effectiveness isn't static. What about, say, dental infections? Seems like antibiotics get prescribed for toothaches sometimes.
They do. And while clindamycin can be used for certain dental infections, it's generally not considered the best first-line drug for routine cases.
Why is that?
Mainly because other antibiotics like amoxicillin or penicillin are often just as effective for common dental infections. But clindamycin carries a significantly higher risk of causing Clostridioides difficile colitis.
Ah, C. diff. That's the serious gut infection, right?
Exactly. It can be quite severe. So for many dental situations, the risk-benefit balance often favors other antibiotics over clindamycin.
That's a really important distinction. It's not just does it kill the bug, but what are the other risks? Okay, so we know what it treats. How does it actually stop the bacteria? What's the mechanism?
The core mechanism is inhibiting bacterial protein synthesis. Remember how you said it stops bacteria building proteins?
Yeah, the bodyguard remover analogy.
Sort of. It targets the bacterial ribosome specifically, the 50S subunit of the ribosome. Think of the ribosome as the cell's protein-making factory.
Okay.
Clindamycin binds to that 50S subunit and basically throws a wrench in the works. It interferes with two critical steps: peptidyltransferase, which is linking the amino acid building blocks together, and translocation, which is the movement of the growing protein chain along the ribosome assembly line. By blocking these, it effectively shuts down the production of essential proteins the bacteria need to function and replicate.
So grinding the factory to a halt. And you mentioned it's used topically for acne. Is the mechanism the same there?
Similar, but with a couple of nuances. Yes, it reduces the population of Propionibacterium acnes, now often called Cutibacterium acnes, on the skin, which is a key bacterium involved in acne breakouts.
Okay.
But it also seems to have an anti-inflammatory effect by reducing the amount of pro-inflammatory free fatty acids on the skin surface. Those contribute to the redness and soreness of acne lesions.
So a dual action on the skin, bacteria and inflammation.
Right. And an interesting point about the topical form: it's usually applied as clindamycin phosphate. That's actually inactive. It needs to be hydrolyzed, basically broken down by enzymes in the skin, to release the active clindamycin.
Ah, so it gets activated right where it needs to work, like a little pro-drug for the skin.
Exactly.
Yeah.
A clever bit of formulation.
Okay, that makes sense. Now let's trace its path through the body. How does it get absorbed? Where does it go? Pharmacokinetics, right?
Right, pharmacokinetics. So absorption first. Clindamycin is quite lipophilic, fat-loving. An important consequence of this, when taken orally, is that its absorption isn't really affected much by stomach acid levels.
So you don't need to worry too much about taking it with food or antacids messing it up.
Generally, its absorption rate is pretty good and consistent regardless of gastric pH. Bioavailability of the oral forms is high. And of course, if you give it intravenously, you bypass absorption altogether straight into the bloodstream.
Which you do for serious infections, presumably.
Precisely. Faster, more predictable levels. Now, absorption in very young infants, like neonates,
Hmm.
that could theoretically be a bit different.
How so?
Well, their gastric emptying and the speed things move through their gut can be more variable than in adults. This might potentially affect how consistently an oral dose is absorbed, but honestly, we lack a lot of specific data on this in that age group outside of critical care settings.
So something to be aware of, but maybe not fully quantified in all situations. What about the topical stuff? How much of that gets absorbed into the body?
Very little, actually. Systemic absorption from topical clindamycin is generally low. Estimates range from maybe less than 1% up to 4 or 5%. So most of it stays acting locally in the skin.
Okay, good. So once it is in the bloodstream, either from an oral dose or IV, where does it go? Does it spread out well? You mentioned bone earlier.
It does distribute quite widely. In the blood, a fair bit of it binds to plasma proteins, around 77% in adults, mostly to albumin and another protein called alpha-1 acid glycoprotein, or AG.
Does that protein binding affect how it works?
Well, only the free, unbound drug is typically active,
Mhm.
but the binding influences how it distributes and how long it stays around. Interestingly, protein binding is lower in newborns and takes until about 10 months of age to reach adult levels.
Another difference in infants.
Yes. And pregnancy also changes things. Levels of AG and albumin tend to decrease during pregnancy, which could potentially mean a higher fraction of free active clindamycin in pregnant women compared to non-pregnant adults.
Fascinating how physiology changes drug behavior. And it crosses the placenta.
It does, yes. It passes transplacentally, so it reaches the fetus. And it's also present in breast milk, although usually in quite small amounts. Reported levels are typically between 0.7 and 3.8 micrograms per milliliter.
So detectable, but low. Worth discussing with a doctor if pregnant or breastfeeding, I imagine.
Absolutely. Monitoring the infant for potential side effects like diarrhea is often recommended.
Okay. And back to bone. You confirmed it gets there. How well?
Pretty well. Concentrations in bone and joint tissues are estimated to be around 30% of the levels found in the blood serum, which is considered good penetration for these sites.
And is that enough to be effective?
Often, yes. For antibiotics like clindamycin that exhibit time-dependent killing, what matters is keeping the concentration above the bug's minimum inhibitory concentration, MIC. A ratio of bone concentration to MIC of around 5 is often targeted, and clindamycin can achieve this for susceptible organisms. It's also thought to be effective against biofilms.
Biofilms, those slimy layers bacteria form.
Exactly. They make infections much harder to treat, especially chronic ones in bone or around implants. Clindamycin's activity against biofilms is another plus.
Right. Okay, so it gets absorbed, distributed. How does the body get rid of it? Metabolism and elimination.
Metabolism happens primarily in the liver. The main enzyme involved is CYP3A4.
The famous CYP enzyme system.
Indeed. CYP3A4 breaks clindamycin down mainly into clindamycin sulfoxide, which is the major metabolite, and also a minor one called N-dimethylclindamycin. Another related enzyme, CYP3A5, also contributes a bit to making the sulfoxide metabolite.
And does anything affect these enzymes, like pregnancy, maybe?
Yes, pregnancy significantly boosts CYP3A4 activity. So potentially, clindamycin might get metabolized and cleared faster in pregnant individuals.
Interesting. And then elimination. How long does it stick around?
The elimination half-life of the active drug in adults is typically around 3 hours.
So half of it is gone from the blood in about 3 hours. Relatively short.
Comparatively, yes, which influences dosing schedules, of course.
And pharmacodynamics. You
Right.
mentioned time-dependent killing.
Right. That means its effectiveness is more related to the duration the drug concentration stays above the MIC rather than how high the peak concentration gets. Sustained pressure on the bacteria is key.
And for biofilms.
For biofilms, the overall exposure over time, often measured as the AU-CMIC ratio, area under the curve over MIC, seems to be more important. Clindamycin generally performs well by these measures too.
Okay, that paints a clear picture of its journey in action. Let's switch tracks slightly to manufacturing. How is clindamycin actually made? It's semi-synthetic, you said?
That's right. It starts with lincomycin, which is naturally produced by a bacterium, Streptomyces lincolnensis. Then, through chemical modification, that chlorination step we mentioned, it's converted into clindamycin.
So, part nature, part chemistry lab.
Pretty much. And groups like the IMARC group actually publish detailed reports on the manufacturing process. They cover things like the specific unit operations, quality control tests, mass balance calculations, raw material requirements, even plant layout and machinery needed.
Wow, quite detailed. Sounds like a complex industrial process.
It is, and crucially, it has to be done according to strict quality standards, good manufacturing practice, or GMP.
GMP, we hear that a lot with pharmaceuticals.
As you should. Regulatory bodies like the Medicines Evaluation Board in the Netherlands, which assess some generic versions, rigorously inspect manufacturing sites to ensure they comply with GMP for both the active substance and the final drug product. It covers everything: cleanliness, procedures, documentation, training.
Ensuring consistency and safety in every batch makes sense. Are there environmental considerations in making antibiotics like clindamycin? There's growing concern about that, isn't there?
A very significant concern, yes. The potential for antibiotic residues in manufacturing waste to contribute to antimicrobial resistance, or AMR, in the environment is a major issue.
So what's being done?
Well, industry groups like the AMR Industry Alliance have established frameworks outlining minimum expectations for manufacturers. This includes complying with local environmental laws, having strong environmental, health, and safety (EHS) programs, characterizing wastewater, and ensuring effective treatment to remove active antibiotic compounds before discharge.
Treating the factory's wastewater properly.
Critically important.
Oh.
It also involves responsible management of other waste streams, like the biomass left over from fermentation processes if applicable, and ensuring monitoring equipment is properly maintained. These align with principles from groups like the Pharmaceutical Supply Chain Initiative, or PSCI.
So a push for greener, more responsible manufacturing to help combat resistance. Good to hear. Now, what about legal issues or controversies specifically tied to clindamycin? We touched on labeling.
Right, the focus on clear labeling to minimize errors is ongoing. But the biggest controversy, or perhaps challenge, is the one we keep circling back to: antibiotic resistance.
It just keeps coming up.
Because it's so critical. We mentioned the rising resistance in group B strep in some places, but it's happening with other bacteria too, limiting clindamycin's usefulness over time. It's a constant battle.
A global health threat. What about safety controversies beyond resistance?
The main one, as we discussed regarding dental use, is the elevated risk of Clostridioides difficile infection (CDI). Compared to many other antibiotics, clindamycin is more frequently associated with triggering C. diff. Even short courses or single doses have been implicated sometimes.
That's a really significant downside to weigh, a serious potential harm.
It absolutely is. And it's why careful consideration of whether it's truly the best option, especially when effective alternatives with lower CDI risk exist, is so important in clinical practice.
Definitely. Any major drug interaction issues we should highlight? You mentioned the CYP enzymes.
Yes, those CYP3A4 interactions are key. Drugs that induce or speed up CYP3A4, like the antibiotic rifampicin, or potentially even flucloxacillin, can lower clindamycin levels in the body, possibly making it less effective.
Okay, so taking it with rifampicin might stop it working properly. What about the opposite?
Drugs that inhibit or slow down CYP3A4 can cause clindamycin levels to rise, increasing the risk of side effects. A very relevant example now is ritonavir, which is a component of the COVID-19 antiviral Paxlovid.
So taking clindamycin while on Paxlovid could lead to problems.
It could potentially lead to higher clindamycin exposure, yes. So a careful review of all medications a patient is taking is absolutely essential before starting clindamycin to avoid these kinds of interactions.
Crucial safety check. Okay, let's touch on the economics. Is clindamycin a big market?
Well, market reports, like those from MyMark, do track clindamycin phosphate prices and demand, suggesting it's an active market segment. The existence of multiple generic formulations like clindamycin Teva or clindamycin doubly pharma mentioned in some European sources points to it being generally available and likely cost-effective as a drug substance itself.
So the drug cost might be reasonable.
Likely, yes, due to generic competition, but you also have to factor in the broader economics. The cost savings if it successfully prevents a costly surgical site infection, for example, but also the potential costs incurred if it causes a serious side effect like C. diff infection, which requires treatment and hospitalization.
Right, it's a balance, the cost of the drug versus the cost of the illness it treats or potentially causes.
Exactly, a health economic assessment.
Okay. Lastly, let's think about its cultural influence, if any. How does it fit into the wider medical and societal landscape?
Well, cultural influence might be a strong term, but its usage patterns are definitely shaped by prevailing medical culture and guidelines. We see recommendations from bodies like the CDC in the US, ECDC in Europe, ASHP, IDSA, NICE in the UK, all influencing when clindamycin is recommended for things like surgical prophylaxis, preventing group B strep, or preventing endocarditis in certain patients.
So the expert guidelines really steer its use. Do prescribing habits differ much by region?
Historically, there might have been more regional variation, but some sources suggest that with increased global awareness of antibiotic stewardship principles, some of those geographical differences in prescribing might actually be decreasing now. There's more standardization.
A move towards more evidence-based, globally conscious prescribing, that's positive. What about patient awareness? How do people learn about this drug?
Patient information resources are key here. Websites like Medline Plus or Medical News Today provide accessible information for the public. They explain what it's for, list common and serious side effects, and give crucial advice like taking oral capsules with a full glass of water and staying upright for a bit to prevent throat irritation.
And reminding people to finish the whole course, I bet.
Absolutely. Patient education is vital for effective and safe antibiotic use. These resources empower patients to understand their treatment better.
Definitely. And one last intriguing point that came up was potential future uses outside of infections, something about cancer.
Yes, that was a fascinating snippet. There's ongoing research looking into derivatives of clindamycin chemically related molecules as potential anti-tumor agents.
Really? How would that even work?
The mechanisms aren't fully clear yet and seem distinct from its antibacterial action. But early research suggests some of these related compounds might inhibit cancer cell growth. It's still very much in the research phase, of course.
Wow. But the idea of repurposing an old antibiotic family for something completely different like cancer therapy, that's quite something.
It really is. It shows that even well-established drugs might hold secrets or potential we haven't fully unlocked yet.
A surprising twist. So we've covered quite a journey today, from its origins and approvals.
Through its many clinical uses, especially as an alternative for penicillin-allergic patients, and its effectiveness in tricky spots like bone.
How it actually works by stopping protein production in bacteria, its path through the body,
The manufacturing process, and the importance of GMP and environmental stewardship.
and the significant issues around resistance, the C. diff risk, and potential drug interactions.
And finally, its place in the market, and maybe, just maybe, a future beyond fighting bacteria.
So wrapping up, clindamycin remains a really valuable tool in the antibiotic arsenal, versatile, effective for specific scenarios like bone infections or in penicillin allergies. But its use demands careful consideration of resistance trends and that significant C. diff risk.
Absolutely. And that potential future research into anti-tumor activity
Yeah.
leaves us with a pretty interesting thought, doesn't it? Given the immense challenge of rising antibiotic resistance, how vital is it that we explore every avenue for existing drug families? Does finding new uses, like potentially in cancer, become even more critical as resistance limits their original roles?
That's a fascinating question to ponder. Balancing the stewardship of current antibiotics against the urgent need for new therapeutic strategies across medicine really makes you think.
It does indeed.
Well, that's all the time we have for this deep dive on clindamycin. Thanks for joining us.
Thanks for listening.